Hi, everyone. Thank you for attending Science Matters Seminar Series today. We are pleased to welcome Dr. Davut Pehlivan, Assistant Professor of Pediatrics and Neurology at Baylor College of Medicine in Houston, Texas. Dr. Pehlivan received a medical degree from the University of Istanbul in Turkey, where he also performed his residency. He completed his postdoctoral studies at Baylor College of Medicine under the supervision of Jim Lupsky, followed by a clinical fellowship in child neurology. In all, he co-authored over 130 articles and received several awards from national and international organizations. Currently, he is a physician scientist at Texas Children's Hospital Rett Center. His research focuses on studying the underlying genetic causes of neurodevelopmental diseases to help developing biomarkers and gene-based therapies. Today, he will discuss the results of a project that our labs have been collaborating on since we're both junior postdocs in the Lupsky lab. At the time, a devastating neurodevelopmental syndrome affecting boys had been discovered. The molecular cause was identified as an increased copy number variant involving part of the long arm of the X chromosome, but details on the why and the how were yet to be investigated. This project comes a long way, but due to Davut's leadership, we are finally seeing all those years of basic research work being translated into medical care for families. Thank you so much, Davut, for sharing your work with us.
Thank you so much, Claudia, for kind introduction and invitation to give me the opportunity to share our clinical work on MECP2 duplication syndrome. Let me make it full screen. I think you can now see the full screen, right? And you can hear me?
Yes.
Perfect. All right, so yeah, today I'll talk about the MECP2 duplication syndrome, the path towards the treatment, because we are starting the treatment hopefully in a month or two. And the work, what we did towards that goal, including the genomic studies and further. I'll start my talk with the history of MECP2 duplication syndrome, then the clinical studies we did, and the genomic studies and the clinical trial part at the end. So when we talk about the MECP2 duplication syndrome, you can understand from the name of it that duplication, including the MECP2 gene, is causing MECP2 duplication syndrome. However, when you talk about dosage sensitive genes such as MECP2, you need to talk about the other part of the disease as well, which is called Rett syndrome. Actually, Rett syndrome is more common and much better known because it is being taught in medical schools as one of the hallmark neurodevelopmental disorders. Rett syndrome was discovered in 1999. The loss of function mutations or the deletion mutations in MECP2 caused that. It is a clinical diagnosis. Rett syndrome diagnosis is a clinical diagnosis. As you can see on the table, there are main criteria and supportive or minor criteria, and there are some exclusion criteria based on the presence of two major criteria and 5 of the supportive criteria. You make a diagnosis of Rett syndrome. So you don't need a genetic testing, and we have several cases who do not have a mutation in MECP2 or other related genes, and the diagnosis of Rett syndrome is still valid. So Rett syndrome is a severe neurodevelopmental disorder, but there are some key features or the hallmarks of Rett syndrome. That's mostly what's being taught in medical schools or trainings. These are midline hand stereotype that I can show here, the midline hand ringing, dysautonomia that I'll mention in the future slides, regression around 1 year of age, which are the classic features of Rett syndrome. So talking about MECP2 duplication syndrome, the first case like we saw, and the OMIM named after this as the LOPS type X-linked intellectual disability for the MECP2 duplication syndrome. Back in 1999, there was a family with 5 affected individuals, and 3 of them died before age 10, and the other 2 were below age 10 again. So it was very lethal condition. And what are the clinical features in those affected family members were swallow dysfunction, gastroesophageal reflux, recurrent respiratory infections, hypotonia with mild myopathy, and atrophy in the brain, and with some dysmorphic features. Actually, some of these features, such as myopathy, is not a feature of the disease, or they are like several of them are not does not fit with MECP2 duplication. They map to XQ28 region, and they propose several potential genes that are contributing to the phenotype, NAA10, GDX, but none of these genes we know that are neurodevelopmental or the DDID genes, developmental delay intellectual disability. After this paper, my current kind of collaborator and mentor, Dr. Huda Zagbe, did the earlier animal studies, who actually discovered the MECP2 gene is causing Rett syndrome. So what she did, she increased the expression of MECP2 twofold compared to wild type. And then the mice started doing enhanced motor activity, contextual learning, and at the molecular level, increased synaptic plasticity in the hippocampus. Those mice developed seizures around 20 weeks of age and became hyperactive, and about 1/3 of them died at 1 year of age. So they had early lethality. The first actual MECP2 gene duplication was reported in 2005. There was two papers. One was Mine's paper. They reported one single individual that the entire MECP2 gene was duplicated, and the patient presented with Rett-like features. That probably is not true today, as we are going to discuss in the future. Later on, Hilda Van Esch is the first group, was the first that really established the diagnosis of MECP2 duplication syndrome. She had 4 families from 13 individuals from 4 families. All these individuals had severe developmental delay intellectual disability, facial hypotonia, seizure and infections were about in half of them, and progressive spasticity. So what she said, that occurred in about half of these, more than half of these individuals. So a couple of years after this, Zlapsky lab, including Claudia, and I supported her for the genomic studies, we started working on MECP2 duplication syndrome. So there are 2 array CGH panels here. In the upper panel, as you can see on the mouse, this is a commercial lab array CGH, and there are 24 probes investigating the MECP2 region. The below is our high-resolution custom-designed array CGH targeting the MECP2 gene at that time, or the XQ28 region. And we had 275 probes interrogating the MECP2 area. So it was a higher resolution, and this higher resolution custom-designed array CGH allowed us to differentiate MECP2 duplications into different subgroups. The first one is tandem duplication, as you can see. There's a beginning and end of the duplication, and MECP2 is in there. There's terminal duplication in the other group. As you can see here, MECP2 is in this red circled area towards the end of the X chromosome. And when the duplication extends all the way to the end, that's called terminal duplication, but still MECP2 duplication. And we had duplication, triplication shown in blue here, and the duplication structure, dup, trip, dup structure. And as you may not readily see such triplication there, but if you follow my mouse cursor here, there's a normal copy level, sorry. And there's an increased level here, duplication, and there's a further increase, that's the triplicated area, and there's duplication here again. So that's called dup, trip, dup structure. Or there was dup, trip, dup normal, dup structure, MECP2 was in one of the duplicated area. Or there was a translocation where there's a duplication of X chromosome, and there's a deletion on the other chromosome, mostly chromosome Y in MECP2 duplication syndrome. So we were able to we published these results 2009, and if you follow, this is the graph, one of the graphs from the paper 2009. As you can see, the upper panel is the genes included in the area, and these horizontal red bars are the duplicated area, and the blue bars are the triplicated area. As you can see, all patients have a different size of duplication and different gene content, as you can see. Beyond that, but despite that, all patients had common overlapping, small region of overlap had included 2 genes, IRAK1 and MECP2 gene. But interestingly, beyond that, different sizes and different gene contents, we found some dup normal dup structure. We call them complex duplication, or some of them a triplicated area. And in some of these triplicated blue bars are including the MECP2 here. So, and what was interesting, we said that 27% of these 30 individuals in this paper had complex genomic duplication. And most of these, about three quarter of these were mapping, the distal part was mapping to a low copper repeat or the segmental duplication area. So we published the dup structure later on with two seminal articles in Nature Genetics. In the first one, we identified the mechanism of triplication formation, and we were able to amplify one or two of the breakpoint junctions in duplication structures. And in the follow-up paper in 2013, we showed that this occurs through FASTA's MMBIR mechanism, one of the copy number variation formation mechanisms. But we interestingly showed that these CNV formation mechanisms are error prone. You may see sometimes deletions, or you may sometimes see mismatch of the bases in the CNV formation structure. At that time, we split the genetic subgroups into three major categories that was including simple duplication, a complex duplication which had multiple different structures that includes dup normal dup, dup trip, that dup trip doesn't include the MECP2, translocation, terminal duplication. There are a bunch of other complex genomic arrangements that we cannot mention all of them here. And the triplication, and in that Nature Genetics paper, we showed that triplication is the most severe MECP2 triplication, actually, not the MECP2, the other triplication area, but the triplications including MECP2 as the most severe phenotype. So talking about the history on the clinical end, when we did the genomic studies, there were a couple of cohort studies, except the Ramaki et al. She summarized the entire literature with 119 individuals. Overall, there are three cohort studies had been published. Lim et al. Published from Australia with 55 individuals. Miguel et al. Published from French cohort, and Peters et al. Published from US Natural History Study. And as you can see, in all these cohort studies, there were varying or clinical variability in the presentation. Just to give an example, for example, in Lim et al. Paper, they reported developmental delay in 80% of the patients. Actually, there is no chance that MECP2 duplication will cause normal development. So, but this paper was done based on parent or caregiver survey. That's why there were some weaknesses, or like there are pros and cons for each studies. And epilepsy, that I'll talk a little bit in the future slides as well, was the biggest hurdle. Our group at Texas Children's Hospital showed that epilepsy is an age-related feature, and as the patients get older, there's higher chance of getting epilepsy. This was the clinical studies for the clinical the MECP2 duplication. Talking about the frequency of MECP2 duplication, again, earlier studies were like not giving the like accurate finding, but in 2008, Baylor Genetics reported MECP2 duplication, not MECP2 duplication, but overall subtelomeric duplications of XQ28 as the most common copy number variation, and 1% of the unexplained intellectual disability in their cohort of 5,000 array CGH patients. However, a recent study from Australia, 2019, this is more reflecting the reality. The incidence of MECP2 duplication is about 1 in 100,000 live male births, or 1 in 150,000 individuals. This reflects more likely the case scenario. The reason for that is Texas Children's Rett Center is the largest and the first Rett center in the country. And we have about 1,000 Rett individuals being followed at our center, whereas we had only 100 duplication patients. So about 1/10 of Rett syndrome makes sense. And we know that Rett syndrome frequency is 1 in 10,000 to 15,000 individuals. So by the time I was finishing my child neurology clinical training at Texas Children, given my background in genetics and the research for the genetics research on the MECP2 duplication, Dr. Huda Zogby invited me to work on the clinical studies for MECP2 duplication. So we, at that time, there were a few cohort studies again, and it looks like it was a very rare disease. We said, let's bring all these MECP2 duplication individuals under one umbrella, and we developed an online registry or server. Okay, the goal for this registry was to expedite the studies towards clinical trial, because there was the clinical, the animal studies for genetic treatment for this condition, but the clinical studies were lacking to do the clinical trial. And so that we can apply questionnaire studies to understand the spectrum of symptoms and the common health problems in MECP2 duplication, and also to maybe to develop validated skills from these through this registry. A family organization sponsored this server, and it was importantly, it was a HIPAA compliant registry, so that reassures parents to register comfortably. So we developed this registry, and we advertised in family organizations' social media accounts, and we started with English, but we wanted to increase the enrollment, and we expanded to Spanish, then the other total five different languages. And so I'll explain you what the advantages of expanding to different languages or not in the next slide. But and we needed a very close communication with families, because families need reassurance. Everyone thinks that I don't want to be guinea pig for my child. I don't want my child to be guinea pig for your research studies. That's why we have to reassure families about that. So far, we had 236 confirmed MECP2 duplication individuals in our cohort. And importantly, about 37 of them were excluded. This is very important because there are other registries from different centers in the world, and they did not confirm the diagnosis, but there are several, about 15% in our cohort, had no MECP2 duplication. For example, they have XQ28 duplication. However, the duplication does not include MECP2. And it includes, for example, other dosage sensitive genes such as GDI1 in the region, and the patient has GDI1 duplication. Or sometimes they have female MECP2 duplication or male Rett syndrome. For example, there are hypomorphic mutations in MECP2, and they are male, but they have the neurodevelopmental disorder. Families think, oh, my child is male and there's a mutation in MECP2. They automatically think they have MECP2 duplication syndrome, but actually they have male Rett syndrome, which is different. Or female MECP2 duplication syndromes does not reflect, duplications do not reflect the full phenotypic spectrum, because they are mildly affected compared to classic MECP2 duplication. So when you do the studies based on a pure MECP2 duplication cohort, it increases the accuracy of your data, and the interpretation of the data is more trustable. So as I said, we expanded to 5 different languages. Despite the Japanese, the Spanish, whatever, I can say that the participation was very low, and it doesn't work to put that effort in there, including the Japanese or the Spanish or other languages. So it's rare disease, right? We wanted to understand how what the families are going through when they are dealing with their child having MECP2 duplication syndrome. So we did a parental burden survey, okay, on caregivers. And the first question was, do you have difficulty identifying medical professionals in your area? Now, 85% of the families reported that they haven't seen anyone who is familiar with MECP2 duplication in most of the cases. There are a few Rett centers in the country. There are 15. So if they're going there, maybe they have seen doctors who have heard this syndrome. But most of the time, the families heard from their doctors that, oh, what is this? And I have never heard this syndrome before. So that kind of gives a huge disappointment to the families. So we asked about the parental burden, right? We asked about how anxious are they about the progression of the disease. And how they feel. They feel moderate to severely worried, anxious about in 85% of the individuals, 83% they are moderately severely anxious about the progression of the disease. Or taking care of an MDS individual affects their social life in 85% of them moderate to severely. Or a relationship with their spouse or other family members. 75% of them reported that it moderately or severely affects their relationship with their family members and spouses. We asked about their job or the personal aspirations. 75% reported moderately severe affection again. Financial well-being, another like 65 to 70%, or their personal health. It's about 75%. It affects them moderately or severely. So these individuals, MECP2 duplication individuals, are having normal body habitus. That means normal weight and height. So we have several individuals who have 6 feet tall and 200 plus pounds, think that, and their parents are in their 40s, 50s, 60s, and they have to carry because these individuals are mostly non-mobile or they cannot walk, unambulatory. So you're carrying a 200 plus pound individual from a bed to whatever, to change their diaper, whatever. So it's causing significant health problems in them. And we asked about their mental health. 90% reported that it affects their mental health. And they are about 75 to 80%, again, they are emotionally exhausted and anxious or depressed in about 75 to 80%. It's moderate to severely affects them. So it's a huge burden on these families. So from these questions, we developed a parental burden questionnaire, as you can see on this table, and this is validated statistically. So we are currently using this parental burden questionnaire in the current natural history study we are running, and also in the upcoming clinical trial. And then we asked, what are the most bothersome symptoms in MECP2 duplication syndrome? So as an expert, we can say, as an expert on MECP2 duplication, I can easily say, because the families come to me and they tell me what is their most bothersome problems, right? So I can easily say that, oh, these are the main features. They are bothering or they are problem for these kids, okay? However, when you go to FDA for a clinical trial, they want you to ask or to involve parents in these kind of decisions. So for example, you can say that seizure is the most bothersome problem, but FDA will say that, did you ask it to the parents, okay? Or whatever. So you have to involve patient or the parent or the caregiver in these kind of survey developments or scale developments. And we did this most bothersomeness symptom survey as the foundation of severity scale development. And as you can see, seizure looks like the most bothersome symptom in these individuals. Other features that's expected with the neurodevelopmental disorders are like difficulties with gross motor skills. That means like your sitting, walking ability, and fine motor skills like using utensils, feeding themselves, or communication, such as like they are saying any words. For example, if they need something, they cannot relate to their caregiver. Severe infections was another thing, and the constipation was a little bit surprised, but it was the top 6 domains were these 6 ones, including constipation. So when we did survey, we did beyond like what is like, for example, in the published literature, it says that epilepsy frequency is between 45 to 60% or 40 to 60% of individuals have it. However, you should go beyond that, and I'll explain the benefit of this. For example, when you say your child has a seizure, they say yes or no, right? But you have to ask, what frequency do their child have seizures? Okay, for example, 40% of these individuals have daily multiple seizures. Okay, that if someone is a neurology background, this is very devastating. Their child is having multiple daily seizures, and about 40%. And then we asked the level of care typical. For example, mostly from these seizures, they recovered about in half of them, they recover immediately, or maybe 85% or 87%. They recover at home without going to ER. but some of them are going to ICUs or the ERs or going to doctor's office visits as well. Also, we asked the most severe outcome. As you can see, about 12% of these individuals had to undergo, they need to be admitted to intensive care unit, and they need a breathing tube, like they mean like intubation for these individuals. And mostly it may take weeks or even months to extubate these individuals. So they are going through a lot from seizures. And when you consider, get this information, it makes sense for them why the epilepsy is their #1 concern. Similarly, as I said, infection was one of the top 6 domains concerns. Again, in the literature, it was only saying lung infections were the common or recurrent respiratory infections, not lung infections. But we split the lung infections to further upper respiratory, lower respiratory, or the lung infection, or middle ear infection is separated. But we asked other infections as well. Surprisingly, 17% reported urinary tract infection, or sepsis was reported in 2%. Again, we asked the intensity of these infections. 42% requires hospitalization, and 26% is admitted to ICU, a quarter of that. So that explains why infections are that big deal for them. Gastrointestinal, only in the literature, there was whether they have constipation or not, which they reported between 80 to 90 or 75 to 90%, and reflux maybe in about half of them in the lab published literature. So it wasn't well studied. So what we did, so as the expert on MECP2 duplication syndrome, you have to work with multiple specialties. Dr. Kay Motil, who is a gastroenterologist and who is seeing Rett patients for the last 30 years, developed a gastrointestinal health questionnaire for MECP2 or MECP2 related disorders. So we applied it through our registry, okay? And here are the results for them. Again, this questionnaire was very comprehensive. For example, when you say, do you have constipation? There are several questions you may pinpoint constipation from them. For example, difficult to pushing out the stool is a constipation, or hard stool, or a big stool. They may be, or needing laxative is a constipation, okay? And you need to investigate them separately. So again, physician needs to be vigilant about that. For example, when you say, do you have constipation? That happened to me, that's why I'm telling it here. The parent said that, no, my child doesn't have constipation. And then, like in the further questions, you say, does your child use laxative or Miralax or Senna or Docusate, whatever? And, oh, yes, she said, the mom said that, oh, yeah, he's taking 3 laxatives. But she thinks that her child doesn't have constipation with the 3 laxatives. So you have to be careful when you are getting the information from families. So we investigated many of the gastrointestinal problems. For example, in the gray one is the reflux, fluid coming from the mouth. As you can see, it has a bimodal distribution early in the first 3 years of life, and towards after 12 to 15 years, it worsens again, goes down and worsens again. When you think about the natural progression of the disease, it makes sense because in the first few years, they have hypotonia-related feeding problems. That's why they are mostly fed by the nasogastric tube, which is relatively milder, benign procedure. But as they get improved in tone, they are fine. But once the epilepsy kicks in, then they require gastric tube. And this can be shown in this figure. Gastric tube requirement increases with age, especially after age 12. And these kids are choking a lot, they drool a lot, and our studies showed like this. And we published these results in 2 different journals, but more importantly, we developed a gastrointestinal health scale specific for MECP2 duplication syndrome, and now we are using this scale for the natural history study and upcoming clinical trial. When you go to FDA, you may use generic severity scales, but they are more preferring disease-specific scale. So validating a scale in a certain disease is important, and that improves, that validates or that increases your chance of results or interpreting your results better. And there, on the literature, there are common problems. I will mention a few slides about the other health issues that were not mentioned in those cohort studies and what we identified. For example, sleep was not well studied or barely reported, and we investigated sleep in 4 or 5 different domains. One was whether they have a problem with sleep initiation, or whether they have a sleep maintenance problem, or whether they have waking up problem in the morning, or they have snoring, or they have apnea. Okay, so it's relatively half of the population has these kind of problems, sleep problems, and there are different features. Dysautonomia, as I mentioned in the beginning of the slide about the Rett syndrome, dysautonomia is one of the hallmarks for the Rett syndrome. What does dysautonomia mean? This abnormal autonomic system. Autonomic system is another nervous system, okay, that controls our body without our awareness or without our control. For example, we don't control our breathing. We don't control our heart rate. We don't control blood flow to our extremities or arm, legs, or body organs, okay? Or we don't control our saliva production or swallowing. We are doing it automatically without our awareness. So Rett syndrome patients are very extreme, okay? They go to the level that they stop breathing, and even you can't do much about that, but they stop breathing for a minute or so, they turn purple, or entire face or the body turns purple or blue. Or the Rett individuals have very cold extremities because there is a lack of enough blood flow to their extremities. They have blue to purple and very freezing cold extremities, and families have to cover them with the warm blanket, everything, and still it's a big problem. And drooling, for example, is common for Rett and overall in general neurodevelopmental disorders. So when we investigate the disease, you have to investigate the overexpressors, such as, like, for talking about MECP2, overexpressor MECP2 duplication and underexpressor Rett syndrome, right? So these features are more hallmark for Rett syndrome, but you need to investigate for MECP2 duplication as well. And when we looked at it, we didn't see a big breath holding or hyperventilation. Great majority did not report that. And when they reported, and you have to be careful, they reported this breath holding and hyperventilation mostly related to seizure activity. When they are seizing, they're holding their breath or they're breathing fast. And abnormal blood circulation, they have little bit cold or cool extremities, but they are not to the level of Rett syndrome. Okay, and the ruling, some of them require medications or Botox in their injections or sometimes surgery in these populations. And we investigated the entire systems, entire organ system. And for the musculoskeletal, we found that scoliosis happens about 1/3 or more than 1/3 of them. And the bone fracture, which is very important, these kids are mostly relying on formula fat. That's why the formulas are missing essential elements such as calcium or vitamin D. And if you don't treat or investigate them, they end up with having bone fractures. Or in the literature, cryptorchidism, undescended testicles was reported as part of MECP2 duplication, but urinary retention, 1/3 of these patients, they never investigated that. Or kidney anomalies were reported in a small portion of these patients. So we went through the entire systems to capture these problems. Visual problems, they are common, but they are not major problems. They are mostly having refraction errors or some lazy eye things. And other health issues that were not captured without our survey about allergy and eczema was reported in about maybe half of the patient's population. So I wanted to highlight, as I said, when you are working on a dosage sensitive gene such as MECP2, this comparison is very important. I'll tell you why. For example, both MECP2 duplication syndrome and Rett syndrome have hand stereotypies. As I explained in the first slide, midline hand wringing is the hallmark for Rett syndrome, and it really interferes with their hand function. When they are hand wringing, or even when they are not hand wringing, when the hand wringing starts in the disease spectrum, in disease natural progression, they left without any hand function. They don't reach, they don't grab, or they don't bat anything. Okay, but on the other side, MECP2 duplication has more autistic hand stereotypes. They have hand flapping at the side or midline, and it does not interfere with their hand function. Or, for example, Rett syndrome, male Rett individuals, not the female Retts, they have tremor, and MECP2 duplications do not have that. So why this is important? For example, when you're treating a MECP2 duplication syndrome and your child started developing midline hand wringing or started developing tremor, then you should concern that whether you're over-treating or over-treating this condition. Okay, so comparison, for example, do they have recurrent infection? All these features are very important. Tease out, even clinically, it can guide you whether you're over-treating or under-treating for a dosage-sensitive gene. So to summarize the clinical studies, rare neurogenetic syndromes are posing significant burden to the parents and society. Online registries are very important to overcome these rare disease study challenges. You can do larger number and more statistically powered results, conclusions. And definitely you need way beyond routine patient physician communication. You have to be very close with the families to have them participate. Their children are having multiple seizures a day. They are in the ICU. You don't expect them to participate in your survey study. So if they trust you, they believe that we are helping their children, then they participate these studies significantly. And again, deep and very comprehensive phenotyping is very important, even to differentiate subtle differences between clinical features in them, and that may guide the treatment. So I'll briefly mention about the genomic studies. When we are doing the genomic studies, clinical studies that I mentioned in the previous slides, we continued enrollment and collaborating with Claudia Carvalho. At that time, in 2009 and 11, 13, we had published only 34 patients, and we expanded to 137 individuals, and great majority of them were seen, but at our center, but many of them also international or very distant kind of states that they couldn't travel. 137 individuals. Again, 34 of them were only previously published. But important, even for those 34, 20 of them had updated clinical information, which gave us very valuable information. And at that time, for example, the child did not have seizure, now they develop seizures. That's why you have to, these updates were very important. And importantly, we developed a standardized clinical assessment form and applied it to all individuals, covered both Rett syndrome and MECP2 duplication syndrome. And MECP2 related disorders are neurodevelopmental disorders, but developmental assessments are always not good enough to do a comparison genotype-phenotype studies. That's why we developed a specific developmental measurement that I'll explain in the future slides. And all these patients underwent a quantitative and deep phenotyping. All patients had genomic studies, drew blood for genomic studies, and all patients underwent short-read genome sequencing and our custom-designed high-resolution CGH. For the tandem loop, we didn't pursue further studies, but for complex genomic rearrangements that we considered, they underwent either long-read genome sequencing and or optical mapping. From a subset of these patients, about 70 of them had lymphoblastic cell line and fibroblast, and we did RNA sequencing and protein measurement from those cell lines. So initially, as we published, we had thought that only a quarter of them have a complex genomic rearrangement, but actually about more than half of them has complex genomic rearrangements, as you can see here. And again, it's split, but the majority of them, a quarter of them are terminal dup and dup individuals. So let's see what the genotype-phenotype data showed. It's our, again, clinical expertise. We split them into 5 different groups: tandem duplication, triplication of MECP2, and others were split into 3. And that includes other complex genomic rearrangements and terminal duplication and translocation. And we expected that the severity will worsen from tandem to most complicated triplication. And as you can see for the clinical features with the p-values on the right hand, For example, normal birth weight is a good thing, right? And it decreases as they go from tandem to triplication. Or you should not have a postnatal complication, but as they get from duplication, tandem to triplication, it gradually worsens. Same for hypotonia, urinary tract infection, microcephaly rate from 3% to 70, 80%. Tube feeding, congenital anomalies of kidney and urinary tract system. Epilepsy did not have any difference between groups. They all had about 40 to 60%, which is consistent with the literature. However, when you look at the age of onset, that's why deep phenotyping is important. For the tandem duplication, the age of onset for seizure is 9 years around or 9 and above in this group, and it's below 2 in this triplication group. It could 9 and above, 6 years, 4 years, it goes down like that. So, and this is very important. Within 1 to 2 years after epilepsy onset, they become refractory, difficult to treat seizures, and difficult to do a treatment for this condition. And there were several features which did not show a statistical significance, but definitely there was a partial trend, such as C-section or the full term or premature birth, or like height or whatever, or either there was partial trend or it was highly common in these populations. For example, constipation is more than 70% in all of them, chewing difficulty more than 80%. Like abnormal behavioral disorders are highly common. That's why you didn't see a statistical difference. I have been doing genotype-phenotype comparisons for the last almost 20 years, and I can definitely say that I haven't done this level of strong genotype-phenotype correlation studies or haven't seen with other diseases so far. As I said, the comparison of developmental skills is a trick. It's not easy to do, because several studies who are doing it, based on developmental quotient. But as you get older, your developmental quotient will go down automatically. However, if you measure their highest achieved gross motor skill or fine motor skills, as you can see, from tandem duplication to triplication, there's a gradual worsening. Tandem dup and other complex group is relatively same. Similarly, highest achieved for gross motor and highest achieved for fine motor skills is same. Actually, we saw the similar pattern for the developmental quotients as well when you measure them accurately. And we collaborated with a developmental pediatrician for this part. Survival. This is, of course, neurodevelopmental disorder, and it's highly lethal based on early studies. As you can see, it has a very nice separation of survival rate. Triplication is the worst. We had only 5 individuals who lived under, they all lived under age 3, and the tandem duplication has the longest living and compared to complex and the translocation group. Just FYI, there is no terminal duplication here. It's a selection bias here, not our selection, but we had only 11 terminal duplication individuals, and they were all under age 10. Even 6 of them were under age 4. So the patient population was small, and none of them were old enough to assess the mortality in these patients. Again, finally, the quantitative analysis, we did HPO analysis for them. And as you can see, to make it easier for you, I make it red rectangles. Triplication has a different band pattern than the others. And the translocation and terminal duplication has relatively similar band pattern. And the tandem dup and other complex has a very different band pattern, okay? So that also validates our findings. With this, we split the complex duplication group into 2 separate. One is, again, other complex group, which has the dup normal dup or dup trip or other complex genomic rearrangements. That trip doesn't include MECP2. And the terminal dup and translocations are separate group, and triplication is still the same, the worst clinical prognosis. So what is the summary of genotype-phenotype comparison study? High-resolution cutting-edge genomic studies showed the complexity of the MECP2 duplication syndrome. And for now, the genomic severity, because we are still enrolling more patients, studying still, we are studying the further groups again. For now, the severity follows in this trend. Triplication is the worst, followed by the translocation and terminal duplication, which are similar to a little bit worse on the translocation, but way worse than the other complex and the tandem duplication. And you have to combining the deep phenotyping with the comprehensive genomic studies is the key for the success. So these results are currently under review, and we submitted our article, but we are also writing the genomic part separately. I wanted to say that like just the dup-trip-dup structure, our paper was just recently published in Cell Genomics. So what we showed here for the dup-trip-dup structure, now we call it Carvalho structure because Claudia Carvalho is the leader to discover this structure. There are repeat elements in the MECP2 region in different orientations, A, B, C, they are all like repeat elements. Depending on their orientation and which LCR involvement, they always make the similar dup-trip-dup structures. And we will continue to writing the genomic part separately. So last thing, I'm going to talk about the treatment for genetic disorders or MECP2 duplication syndrome. As you know, there is a surge, like there is an increase in the treatments for genomic treatments for rare genetic syndromes. Okay, and Spinraza, which was developed as an antisense oligonucleotide for spinal muscular atrophy, was the first approved, as followed by the Zolgensma gene replacement therapy for SMA or spinal muscular atrophy. Then for blood disorders such as the hemophilia A or the Duchenne muscular dystrophy. So there's a huge increase, and currently, as far as I know, about 1,100 ongoing clinical trials for rare neurogenetic syndromes at FDA. But you only know the ones they are successful, right? There are several ones who failed to gene therapy trials. For example, I was at the Rett Center, and Novartis was about to do the gene therapy trial for Rett syndrome, but they had to quit or they had to cancel it. Biogen had two failed clinical trials, cost them $500 million. And I don't know if you heard the news, Huntington ASO trial was a huge expectation. They were expecting treatment, but the Roche study failed. The outcome measures did not meet. So there were reasons for the clinical trial, but there are several failed clinical trials, even for the gene replacement therapies. So Dr. Hida Zogby, as I said, in 2015, she developed the antisense oligonucleotide treatment for MECP2 duplication syndrome. As you can see here, when you treat with the antisense oligonucleotide, MECP2 is a regulatory gene. It's a methylation gene. That's why it is regulating thousands of genes. And when you treat with ASO, it flipped their expression pattern. So ASO was working, and it decreases the mRNA level gradually in a dosage-dependent manner. These are the MECP2 duplicate. This ASO treatment was done in mice study. Sorry, I forgot to mention that. So the epilepsy, as I said, the biggest hurdle for these families is when you have a wild-type mice, there is no epilepsy or seizure. In the transgenic mice who has MECP2 duplication, they have many seizures. These like dark lines are seizures. But when you treat with ASO, it cleared the seizures. It has a significant impact. And when you look at the other features, such as hypoactivity or anxiety-like behavior or abnormal motor behavior or the social behavior, they all improved with the ASO treatment. So when you're targeting a dosage-sensitive gene such as MECP2, based on our knowledge, we know that there's a safe range of MECP2, not 100%, everyone has 100%, about 85 to maybe 130%, there's a safe range of MECP2, this green zone, okay? When you have too much of MECP2, it causes MECP2 duplication syndrome. Or when you have little, you have Rett syndrome. So I didn't show those slides, but we know that we have patients who have MECP2 levels up to 454% increase or 4.5-fold compared to normal levels. So when you have, follow my cursor here, when you have a threefold increase of MECP2, And when you decrease it from 300 to 200, you won't rescue the phenotype because you are not giving enough treatment. For dosage sensitive genes, you have to be exactly around 100% level to be successful for the clinical trial. Or if you give too much of the ASO for MECP2 duplication, you're going to convert to Rett syndrome. So too much or too little is problem. Similarly, now at our Rett Center, we are doing gene therapy trial for Rett syndrome. So if someone has a 30% MECP2 level and with the gene therapy, gene replacement therapy, you go to 60%, from 30%, you won't rescue the phenotype. You have to give it exactly around 100% level. Or if you give too much, you're going to convert to a MECP2 duplication syndrome. So I would like to end my presentation with this good news. Ionis Pharmaceuticals just announced a month ago that we got the FDA clearance to run the clinical trial for ION 440 for MECP2 duplication syndrome. And as highlighted here, the clinical trial is designed based on our genomic findings, and we will start with the tandem duplication or other complex genomic duplications, and in the phase 1, and then gradually expand to terminal loop and translocation and triplication groups. So this is that, as far as I know, this is the first individualized treatment trial approach for a genetic-based treatment. With that, I would like to thank all patients and families and my very close collaborator, Dr. Claudia Carvalho at PNRI, Jim Lobsky, our former mentor, who initiated the MECP2 duplication genomic studies, my current mentor, Hida Zogby, and for her Western and the RNA sequencing studies, and Anna Lindstrand from Karolinska for genome sequencing. And this project had multiple supports from NINDS, NIGMS, and several patient foundations to run it. And with that, I would like to end my presentation here and happy to answer questions you have.
Thank you so much, Davut, for a great presentation. Let me see if there is any questions in the chat. I saw some claps, people here. So I think one question that I have, Davut, it's like, we see this is the first study of this type of gene, right? That is lower, that has dose-sensitive gene that has problems if you have higher expression or lower expression. How do you think this is going to impact other syndromes that have similar features?
So now we are planning to apply to this for another like dosage-sensitive gene for RY1. So I can tell this part, for example, like as I said, SMA, spinal muscular atrophy, gene replacement therapy, both and the antisense oligonucleotide. Now they are both FDA approved and they are being used clinically in 40+ states in the country, this kind of approach. And so what they found, like now the spinal muscular atrophy has a treatment, right? So every baby born in this country, or most of the like several European, and most of the countries in the world are screening for SMA. And when they detect the SMA, they give this genetic treatment in the first 2 weeks of life. And surprisingly, not expectedly as well, when you give gene therapy to these individuals, some of them live a normal life. Okay, that's amazing. And I don't know if you know of like SMA, spinal muscular atrophy is very devastating. First of all, they have a normal intellect, their muscles are not working. And if you give, like if you leave them with the natural progression, by 2 months, they will require a tracheostomy. Because they cannot breathe on their own. And they are hooked up to the machine. And by age 2, the most severe forms, they die. SMA type 1 dies before age 2. Think that when you give gene therapy, they live almost near normal life in some of them. But as like in the clinical practice, now they are seeing that several patients who have SMA, but they don't respond. Now, like the Ionis, at least, they're investigating what is the genetic mutation is maybe playing role. Some of them are not responding enough. So as you said, this opened the new area. Now you need to look genetic structure or the mutation type, why some medications are working and some of them are not working.
Yeah, and I think the other point is like we may be able to find other genes that may contribute to some of the syndromes, right? Because the syndromes are several genes are involved in the rearrangements, and sometimes we don't know they are involved, right? There are some like the recombinants that we have genes in the XP that we can expect, right? So I guess that's doing this type of studies, I think we may be able to find even novel genes, right?
You're 100% right. Like my clinical experience is this, first of all. So even the other genes are playing a role as well. For example, GDI1 is one of the well-known now in the region. First of all, not every patient has GDI1 mutation, but GDI1 is more causing like mild to moderate. So I can definitely say, comfortably say that MECP2 is the main gene driving the phenotype in this cohort. You're right, and families are aware of that. They are aware that you're not going to fix them fully. You're not expecting when you give it to a child, they're going to stand up walking or talking. So even let me say that even if you rescue even if you improve the seizures, this is a groundbreaking treatment for these individuals. And I know that for the mouse studies, when you give the ASO to even old age mouse, it cleared the seizures in them. So we are very hopeful for the trial.
Yep. There is a question in the chat.
I can see
Wait,
that. Our patient.
Wojtek, do you want to unmute yourself and ask? Let me see.
Hello.
Hi, one here.
Hi. Thank you for the wonderful talk today. I'm just curious that you mentioned that the dosage is critical, too much repression, and so then each cell is going to express a different level of the MECP2, probably even the brain and the different types of neuron glial cell is going to be expressed. So do you have the idea that how you can find optimal concentrations for ASO for treatments?
As that's probably the feature of gene therapy trial.
Mhm.
So you're still giving very generic. For now, what we are dealing with for gene therapy trials, there's the blood-brain barrier. You cannot pass it, right? Our goal is to pass, and that's why these patients will get either through the lumbar puncture, you're gonna get to overcome it, or to inject to their ventricle. So when you inject it to cerebrospinal fluid in the ventricle for these human, like we are doing it for Rett syndrome through the intrathecal. So as you said, the cells will absorb how much they can. So we are not gonna go, oh, these parts will get this enough or not. But that's a very important part. Probably if you can achieve that, you're gonna get full recovery from phenotype. You're right, but we are not there yet, I can say.
Yeah, thank you. It's wonderful talk.
Thanks. And the question is, how are patients selected for clinical trials? I believe you mentioned that translocation is excluded from first trials. Yeah, thanks for correcting, because when the FDA announced, or the FDA, not the FDA announced, the Ionis announced in the clinicaltrials.gov, many families, as their forefront for the families, they immediately called me, why my child is excluded from the study? We did a lot for the study. So they're not excluded. So it's the first phase of the study. We won't study the translocation or terminal duplication or triplication. So it's going to be in the maybe a year or later or so, then they will be included. But there will be definitely trial. I haven't showed that data because it's not very accurate. When we did the protein and the protein level in our pilot study, we found that the complex group has about 2.5 to 3.5 fold increase, and the triplication is a 4.5 fold, 4 to 4.5 increase. We couldn't see the same thing in the entire cohort when we did it over the 67 individuals. But that challenge comes from because MECP2 is the nuclear protein. It binds, even the protein binds to nuclear DNA. That's why the measurement may not be accurate. But we still believe that we need to give a higher dose for the terminal duplication and translocation, but that's going to be done later on. And the other question is, what is the clinical trial looks like? Is it a shot? Okay, yeah, it is lumbar puncture. They will get every 3 months through lumbar puncture. it's not going to be only Texas Children's. There will be 5 or 6 sites in the country. Nothing close to Seattle, unfortunately. I can say that. The closest will be California and maybe Colorado sites for that. They're going to do the studies in the red centers. And as far as I know, there is no red center in Seattle. Okay, Chicago, I know what is that center? Gillette. I think Gillette is close to Chicago area. And they're like, we are very dedicated center for MECP2 duplication syndrome. That's why we are leading most of the studies, and most of the other centers haven't started the natural history study yet, except Gillette. They're very good, and I think they will be the second who will start the clinical trial as well. So yeah, if you have patients, definitely you can refer them to Gillette Children's. Or there is the Nashville Vanderbilt. If you want, you can refer them to Vanderbilt. I don't know how close Vanderbilt is.
Okay, let's see if there is any. Oh, okay. I think that's it. I don't see any other hands or questions in the chat.
Oh, yeah.
Okay, thank you so much.
Thank you so much.
Yeah, I just want to say that in August, we are not going to have Science Matters. We skip it, but we are back in September to discuss newborn screening. So thank you, everyone. Thank you so much, Davut, for this wonderful work. Bye, everyone.